Welcome back to the Many Faces of Alzheimer's, brought to you by the Institute of Memory and Cognition at Tala University Hospital, Dublin. I'm Fionnuala Sweeney. In this episode, we join Professor Seán Kennelly and the team for a Friday afternoon clinic and hear from BREDA Comiskeey, who is living life to the full despite having Alzheimer's. I spoke first to Derek Wild, the administrator for the memory service, to find out what his job involved.
Lots of work. So mainly we get the referrals in, we get the consultants to triage them. They say routine or urgent. When we get them in, we get them booked in for assessments. And then depending on the urgency, we talk about them in the MDT meeting that you're in yesterday and today.
The clinical
conference today, yeah. And then Sean will say routine, urgent, so then it's up to us to find space to move them in.
So you're doing a lot of scheduling?
Yeah.
So how often are there clinics like today, the one this afternoon?
Twice a week, every Wednesday and Friday. But we're meant to have a max of 12 patients, but we're booking about 16, 18 every week now.
So this is the stage where they've had their assessment, they've had some time to process the tests and everything that went on, and then they're here now to get the results.
The results, yeah.
And what are they like when they come in?
Depends on the patient. Some are nervous, some are just happy to have an answer, and some patients are fine, so they just want to be reassured.
And what about when a patient receives the diagnosis of Alzheimer's or a dementia of some kind and maybe is a little distressed by this? What happens then?
Well, we have many supports. So they could be linked in to public health nurses, and we have our own social work if they need help to talk to somebody. They could have a mild cognitive impairment and they get booked into our brain health clinic, which is Graham, or they could be diagnosed with Alzheimer's dementia and to be booked into the post-diagnostic clinic with Cathy. So we keep track of them. We support them there onwards. Is
there ever a typical day?
No. Every day is different. I look forward to coming into work every day. I've had grandparents that had dementia and also it's interested me. And
do you feel part of a team or
100%.
A wider team rather than just the admin team?
More of a family. I think we're all a family. When we have our case conferences every Thursday and Friday, we just feel like one unit and we all help each other.
This is our Friday afternoon clinic. It's really the main outpatient clinic where I get to follow up on people in particular, but also we would do some disclosure diagnoses. So some people will have their first disclosure in this clinic. The way this clinic operates is that the registrars will come down typically around 1:30 and they'll start seeing people straight away. They'll be revisiting the different aspects of the history that we've discussed in the case conference, doing the physical examination, in particular neurological examination, making sure that people's walking and any other movement symptoms in particular, or any visual symptoms, that we've teased those out and understand exactly what they might be if they're there. Go through their medicines, which is really, really important, and make sure that there may not be any medicines that are complicating the picture. Then after that, they'll come in and they'll discuss with myself, and then I'll be armed with this more recent review. Just means then that my conversation with people is very much around what they're noticing, what they want to talk about. It isn't about repeating assessments. It's not about repeating tests. It's really focused on what I think might be going on, what might be causing the symptoms, and hoping and trying to make sure that they understand, okay, well, what the next step is, whether it's that I'm telling them that there isn't a significant problem. And remember, it doesn't mean that they're not living with symptoms. They obviously have symptoms. It just means that it may not be anything sinister like a neurodegenerative cause that's causing those symptoms. But also, if it's a case whereby they have mild symptoms, what the next steps are. We'll talk to them about the brain health clinic and reducing that risk for progression. Or if they have dementia, it's around what's the cause of their symptoms and what we can do to help them live as well as possible with it, and to reassure them that this is what we do within this clinical service, that we have lots of other third sector partners that we work with to support them, such as the Alzheimer's Society and Alone and Xwell, the exercise service that we work with, and that while it's a scary and unique scenario for them, we don't have to fix it all today. We don't have to come up with all the answers today. And that Cathy then, who leads on our post-diagnostic service, will touch base with them within 6 weeks to reiterate what the diagnosis is and see if there's been any questions or issues in that period of time from my first consultation. And then I usually see them about 2 weeks after that, so about 8 weeks from when I do the discussion with them today. And that's often to see how they're getting on with any medicines that I might have started them on, if they've any questions around the diagnosis and what we talked about beforehand. Sometimes we might have done additional tests. But also they might bring in a different family member that they think it might be useful for them to hear from myself exactly what it was we discussed. So those are the stages. And typically what I would do is I'd see somebody back at least within 3 months of me making the diagnosis, then at least 6 months after that, just to see things are stable. And if everything is good at that stage, I'd probably see them then maybe 9 months later. So we're gradually pushing it out so that they realise that they're not dependent on having to come to ourselves, and that they get to grow their own, if you like, support infrastructure, but with the reassurance they can always touch back in. So they don't have to be waiting for appointments to get back in touch with us. They can always get back in touch with us if something new arises. Typically after about 1.5 years or 2 years, when hopefully most people are quite stable and they've adjusted to the diagnosis, I give them the choice of either being followed up by their GP and coming back to me if there's a problem, or else they can continue to come in to us and just have a catch up on an annual basis. I'd say it's probably about 50-50. Some people say, actually I have enough information. I realise now that it's quite stable and there isn't any new medicines that I have to go on at this stage, so I'm happy that my GP follows it, and if there's an issue he can refer back. And then another half of people are maybe more reassured to keep the connection with themselves, and it's their choice.
I saw a 66-year-old female. She subjectively has reported having memory issues over the past 2-3 years since her fall. So she'd had a fall with a head strike at that point, and since then has been having progressive memory issues.
Okay, and I'd say, hospitalisation. And do we know if she had delirium?
I don't know if she had delirium in her period, but she did mention she was in and out of consciousness for the first week of that. She can't recall large periods of it.
Exactly. Delirium is an acute confusional state that people who have a mild memory difficulty are at greater risk of developing, and it can be very disproportionate to the original trigger. So sometimes it may get it from a simple urinary tract infection, sometimes it will be from a fall, oftentimes it's as a result of even a hospitalisation. Sometimes there are other triggers, like there may be a background history of alcohol intake, and when you take away the alcohol you get a withdrawal delirium. Sometimes it's because of medicine, so people may be on sleeping tablets or benzodiazepines, and when they stop taking them because they come into hospital and we didn't know they were on them, they'll develop a delirium as well. So there's lots of different things that may trigger it, but what it is a very abrupt decline in somebody's cognition or thinking, and in particular their attention and their orientation. Sometimes it can be coupled with a psychosis or hallucinations, but actually often the most dangerous delirium is what we call hypoactive or quiet delirium. It's where the person is quietly sitting in the chair and, unbeknownst to anybody, is completely disorientated and confused, and they're not necessarily doing the loud acting out that somebody who has a hyperactive delirium is doing, and as a result, unfortunately, it's associated with much more significant long-term consequences, a much greater likelihood that they may develop a dementia as a result of it, or progress into a dementia, and a poorer chance of recovery to where they were at beforehand, or even mortality. So hypoactive delirium is one of those significant causes of morbidity in older people in particular that come into hospital.
I've got a 76-year-old lady. This is her first visit to us. Yeah, so we assessed her as probably a mild cognitive impairment, but there's also quite a big bereavement that's been going on. So her husband passed away in September last year. Quite a sudden occurrence, and she certainly had a lot of depressive overlap symptoms in that period since. But actually those symptoms have really improved a lot, both on her account and the daughter's account who's here today. But definitely the daughter's giving a 1 to 2 year history that predates the husband's passing. It sounds like it's kind of
the memory issues?
Yeah.
And we've talked before about often at these prodromal or early stages where mood and anxiety, even in the context of life events, may be an indicator of something else going on, especially if there's some amnestic or memory symptoms associated with it. And we also know that women are more likely to have mood, anxiety symptoms as a prodromal feature of Alzheimer's disease than men. And it goes back to what I would always say is, brain health and symptoms, they're not the same. Everybody is different, but there is a sex difference also in some of these symptoms. Mm-hmm. So we're waiting for scans still?
Yes, I checked, it's approved. No date set yet.
Hasn't had any biomarkers.
No.
Do you think would be interested? Probably would be useful, wouldn't it? I think where you're unsure whether or not some symptoms may or may not be related to mood, it's useful to have a sense later on, especially when you're saying to somebody, so yes, mood might have been a factor, but that's been addressed, and the reason why these symptoms are persisting is because we found these proteins.
Yeah.
I probably would, because,
Okay.
for certainty. It'll be up to her.
Yeah.
So typically what we do is we have information sheets on what are the biomarkers that we're doing, what's involved in them. We give them those to take away, that they can mull them over for a week or two, and then we call them and say, we're going to schedule an appointment. Are you still happy for us to go ahead and do that? And how I often present it is that it's not essential, but it helps me give them the best information and the most accurate information from the point of view of prognosis and what they can expect and what might be causing symptoms, especially if it's somebody with milder symptoms under the age of 80, and where there might be these other confounders going on in the background. It just gives clarity.
Yeah.
And then we would also follow her in our brain health clinic.
I chatted to her quite a bit about that. They're also open to the idea of the memory technology resource room.
And I see that you've gone through that checklist to outrule other, like Lewy
Yes.
body and
Yeah, I
those.
went
And
through-
that's the other, I suppose, memory complaint that can present with anxiety and mood symptoms, and it can get missed if there's a bereavement or something else.
Yeah, kind of clouds
so
things.
yeah, she's no other symptoms though that look like it.
No, but she's very much not aware about a lot of this.
Anosognosia is a term that we use which describes where a person isn't aware of their deficit. We see that commonly with people who have a memory difficulty, in that they may not have the awareness of their memory difficulty, and then you can get this bit of tension that arises between people like the family, sometimes ourselves who are observing it, and the person who thinks this doesn't sound like them. It's not what their experience is or their impression is. So I suppose in a consultation you've probably already been trying to smooth out, and it's to try and take person A and person B and get them
Yeah.
a little bit
Somewhere closer to the middle.
closer to each other and their
Yeah.
story, and to reassure.
Yeah.
So we've just seen a Friday afternoon clinic. Is there a typical Friday, or are you just always prepared for the unexpected?
Oftentimes we're seeing people at intervals, and you're establishing what's happened in between those intervals, and things may have changed from the point of view of the person within the memory clinic, and to a certain extent that's expected. But it's actually the other things that maybe require more attention, such as a health implication for the person who's supporting their care, or a particular incident that may have happened, or a concern around somebody's safety or welfare that requires a more urgent attention. So we have a system whereby people ahead of coming into clinic send a communication to Derek or Loredana that highlights if there's a particular issue that they think might be sensitive in clinic that they want us to address. So I'd usually get that in the week before we see them in clinic. But a lot of the times people don't have the time to sit down and do that. So we're having to unpick the issue or whatever it is, the topic that somebody wants to talk about in clinic right there in real time. Many of the people that we would see in a clinic on a Friday would be progressing through different stages of living with their dementia, and some of them would get to more advanced stages where they may have symptoms of agitation, exit seeking. Sometimes there may be conflict between family members. Sometimes that can actually go beyond just verbal conflict into physical conflict. So how we approach it is really trying to get people to understand where is the origin. So to try and see it from the perspective of the person who's living with dementia, who may be perceiving a threat, maybe perceiving that somebody said something, maybe misremembering an event or something that happened at an earlier time, or maybe remembering something that happened at an earlier place or time, but now is getting it out of the wrong context. And we do know that a lot of people who are living with dementia will relive trauma and will relive traumatic life events. And those are often some of the more accessible memories that the brain has to retrieve. And when it feels under threat, it might actually just, if you like, project some of these emotions. And so it's to try and help people who are supporting somebody, the carers, to understand that what somebody might be saying that they're responding to may actually not be what they are responding to. Almost 15-20% of people who would attend the memory service would have historical abuse, either from childhood or from adulthood, sometimes domestic violence, violence within the home at different stages of life. and often haven't discussed that with family. And there can be almost a double anxiety for an individual. And we've looked after people who, one of the main things that they have said to me early on is that they're losing that ability to keep it secret and that they're worried about it spilling out. And I've had to do consultations where I've had to give family double bad news, where we have been doing a disclosure around diagnosis, but also supporting that person to make a different disclosure to the family about an incident of abuse that may have happened earlier in life. And sometimes that might have involved another family member.
And more than once, I heard you talk about perhaps giving a phone call to somebody or setting up a meeting with family members.
It's normal practice for our service, and it would be normal practice not just for the medical team, but for the nursing team and for all of the other health and social care professionals to be linking back in with people right throughout the week. It's a 5-day clinical service. One of the things I try to, I suppose, reassure people around is we don't have to come up with all the solutions in the hour or half an hour that I'm talking to somebody, that we will have ongoing contact. Sometimes I have to go away and get more information for them. Sometimes they need to go away and talk to other family members.
And sometimes you have to have conversations that are difficult. I heard you talking with some of your team about going in to see somebody and addressing risk factors that are contributing to their condition. How do you go about addressing that?
With honesty is the key thing. There's lots of different factors that can contribute to somebody developing a memory issue, but there are also things like alcohol consumption, and it may be that it's a contributory factor. There are things like vascular risk factors, so where people have untreated blood pressure, high cholesterol or diabetes, which has also contributed to them having their memory issues. Where it's, let's say, something like alcohol, and it's often one of those contributory factors that's difficult to address for people because for some people it's one of the few things that gives them joy. So you don't want to deprive them of that, but you do need to give them the information and say that we think that this is a factor here. So what I often try and do is to get them to a graded approach of abstinence for a period of time for me to be able to repeat their assessments, repeat their cognitive assessments. And then I can actually specifically say, well, yes or no, alcohol is actually a factor here.
Have you seen changes in people who have perhaps gone into full-time care and haven't had a drink for several months?
So abstinence can have dramatic impacts, and many geriatricians would be able to recount incidences where somebody, after 6 months or so of alcohol abstinence in a nursing home, almost woke up. Their cognitive reserve and their cognitive performance increased dramatically, and they had a level of alertness. There are some people's brains that are very vulnerable to the effects of it, and it takes quite a long time to wash out those effects. So even when you stop drinking, it can take months and months before you will see the benefits of it. So it's probably one of the most complex risk factors for us to navigate within the clinic because we don't even fully understand its direct relationship to neurodegenerative causes of dementia. So how it is a factor in contributing to the overall risk of developing Alzheimer's disease because it's such an important risk and has such a toxic effect in its own right.
You're painting a picture of incredible skill that has to be applied when navigating these kind of conversations. Everything from can I continue to drive to talking about abuse. How much training have you had, or how much of it is just part of who you are?
I think a lot of it is around experience, and the more you do it, the more you learn from your mistakes of what you did well and what you need to do better at. And then you're imprinting that and observing other people do it. And I have been really, really fortunate to work with and train under excellent clinicians. And some I would have observed and say, I can see why they do it that way. And then there are other clinicians I might have worked with and I say, okay, I'm not going to do it that way. And it's not necessarily that they're doing anything wrong, but it wouldn't fit my personality. So I think you have to be true to your own personality. And I think amongst ourselves as clinicians and when we're trying to train other junior doctors who are coming to work in this area is you have to be true to your personality. You can't mimic, so you have to find a way of communicating that empathy and understanding within the context of your own personality. And some people are very analytical, and it's absolutely fine. Your patients who attend the clinic will completely understand that that is the personality type of their doctor, so long as they're true to it.
My name is BREDA Comiskeey. I'm 69 years of age. I live in County Kildare. I'm a mum, 5 adult children, loads of grandchildren, great-grandchildren, widowed young. About 2.5 years ago, I think I got a full diagnosis of early onset dementia, but I'd had difficulties for 2 years, maybe more before that, not understanding what was going on. The first thing I'd say is that I lost my hearing. Nobody in my family had hearing problems, and it was just unusual. And also I was only in my early 60s, so that was a bit of a surprise. I worked as an accountant. I was quite good at what I did and quite confident. And then I started to have difficulties in work, not understanding what should have come to me naturally and so easily. Started to jumble in my head. And I had very little understanding of what was going on.
Were you mixing up numbers?
Yeah, and not understanding the most rudimental things that I should have, and also not being able to keep track.
And what did you think it was at the time?
Everybody says your age. And of course, I was gone 60, but I wasn't 100% happy with the fact that I could just pass it off as getting older. I had to stop work.
Really?
Yeah. I'm an active person and I couldn't just do nothing. So I got a job as a cleaner because I analysed what I could do and I knew I could mind children or clean. They were things I was good at.
Had you been to a doctor at this stage?
No.
And at what point then did you decide, or did you feel you need to see a doctor?
I started getting lost
Really?
in places that I went walking that I knew very, very well. I was in areas that I walked every day. I do walk a lot. And also during COVID, I had walked a lot, and this was the next year, in 2021. My head was confused, being in places, knowing I was lost, and absolutely terrified. I was going to ring the emergency services one day, and luckily enough, the phone wouldn't pick up any service. Eventually, I found my way out of it. But I spent hours on a hot day with a dog, lost in a small wood.
So that prompted you to go to the doctor.
I did, yeah.
And what happened then?
I went to my own GP, who I have known for 20 plus years and who knew me very, very well. He did a desktop test with me. He said I passed it, but he felt with what I had told him that he was going to refer me further on. He'd investigate who was the best and where was the best to refer me to. Hence, I was referred to Sean and his team for tests and follow-up.
And that's where you come in, Sean.
Yeah, so I think there's a few really interesting points that you bring up around your story, Breda, and one is the hearing issues. Oftentimes people, when they think about things like Alzheimer's disease, they think about memory. They don't necessarily think about the other stuff that can go along with it, such as visual symptoms. And we know hearing symptoms as well sometimes. And hearing loss is actually one of those things that people often underappreciate. First of all, we know it's a risk factor for developing dementia or Alzheimer's disease, but then also people misinterpret their hearing not being as good because the brain isn't necessarily able to put the messages or the sentences together as quick as it would have done. So it's almost a comprehension symptom as much as it is a hearing symptom. The ears are technically working, but the part of the brain that puts together that auditory input isn't knitting those words together and making the sentence make as much sense. So the person's perception is I mustn't be hearing it as well.
If I can just jump in there, what was the definitive diagnosis?
I had a brain scan and they found something in the back of my head. I can never remember the name.
Posterior cortical atrophy. It's a load of words.
Yeah, I can.
What it is a type of Alzheimer's disease where often you have visual symptoms and difficulty with calculations, sometimes a little bit of clumsiness. And those symptoms are more marked than memory symptoms initially. When we look at a brain scan, the first thing is the majority of people with Alzheimer's disease, their brain scan is usually unremarkable. They have a little bit of shrinkage, but it's generally not that different to the brain scan of anybody else who's getting a little bit older. What we do then is we look at very specific areas of the brain to see are they a little bit more shrunken than other areas. And I think we did see some features of that, as you say.
Yeah. Sean mentioned about the clumsiness. I had a lot of that, a lot of accidents, broke bones from falls. But I'm lucky enough that it's eased off those types of symptoms.
And why have those types of symptoms eased off?
Mostly people adapt. It's navigating around an environment, and if you're navigating at the pace that you would have always done, is probably when you're likely to trip over things or bump into things.
When I realised the clumsiness was a symptom of what was happening to me, I then became so careful. I'm very aware of all my movements. I'm slower. I've stopped breaking all the stuff in the kitchen.
So having a diagnosis, having come to see Sean and his team, really prepared you to change or adapt to a new way of living that might not have happened had you been continuing at the pace you had been before.
If I hadn't received the advice and care here, I don't know where I'd be, because I would have expected the worst and probably gone that way. But with all I've learned here, they give you leaflets and booklets and information. And when I had a diagnosis, I started to read on the internet and listen to as much as I could about what I had.
So you were interested in learning more rather than saying, okay, I really don't want to know anymore.
Information was help. I didn't want to turn my back on it. I felt that was the wrong thing.
But if I may say, having talked to you now for some time, Breda, I wouldn't think you had Alzheimer's. I wonder, do you feel that most people don't know that about you?
My children and my grandchildren know that. I'm not well, as we term it. But one of my grandchildren said to me quite recently, it's only now and then, Nanny, you get lost. Not lost going out, but get lost in my head. I do forget things. And if I didn't have my diary and all the aids that have been recommended to me by the hospital, and I religiously every evening sit down, sometimes at lunchtime as well, and write down what I've done that day.
So that keeps the brain functioning.
Yeah, it's a log of things. I often use the phrase in the clinic that memory is a bit of a luxury commodity. We all want as much of it as we can, and it doesn't matter whether we're 20, 40, 60 or 80. We all want to be able to remember, certainly on the moment, the person or the context that we're in. But in reality, if we have prompts or individuals to jog our elbow, if you're taking notes or have the board in the kitchen that says this is the day, this is the date, this is what I have to do, if you're able to orientate a starting point, a lot of the times you're going to be able to fill in the rest of it. From conversations I have with people who are living with memory difficulties and Alzheimer's disease, oftentimes that first starting point is what's difficult. So if you just focus on one thing, and that is to always be able to go, this is the starting point, then actually a lot of the other stuff will follow in.
So what is it you would want people to know, Breda?
It's not the end of the world. That's the first thing. Don't be afraid to go to your GP. If you have worries, try and get a diagnosis. See what is going on. My GP was very surprised with my diagnosis because he had known me so long and I had been so well for so many years. And he's delighted with my progress. So am I. All these little things that people put down to, oh, I'm getting older. I feel people should stop ignoring that. Stop accepting that I'm just getting older.
And take steps to embrace and live a better quality life.
That's the perfect way to say it, yeah.
BREDA Comiskey bringing us to the end of this podcast. In the following podcasts, I meet up with some of the clinicians we heard from briefly in the last 3 episodes and learn more about their role in helping the team reach a diagnosis, as well as how they support people living with dementia and their families. We also hear from the patients about the ups and downs of living with mild cognitive impairment and Alzheimer's. I'm Fionnuala Sweeney, and you've been listening to the Many Faces of Alzheimer's, brought to you by the Institute of Memory and Cognition at Tallaght University Hospital, Dublin. This series is available on Tallaght University Hospital's YouTube channel or wherever you get your podcasts. If you found this episode helpful, please share it on and subscribe to the series to catch up with earlier episodes.